You ask the patients that we've had this program with, they are ecstatic about it. I mean, they really are clear-headed going into the operation. They're clear-headed coming out, and it's really been fantastic. Pain is really dealt with very differently from every person. It's multimodal, meaning it's physical, mental, social, and probably cultural in some ways. So now we take a much broader approach to understand what's it going to be like for this person after their, for instance, orthopedic procedure. Rather than just lean towards one medicine that's going to do all that things, it's preparing the person for the operation, and pain management is really taking in all those factors afterwards. It wasn't too long ago we used patient-controlled analgesia, which is a PCA. It's a pump that they get to hit the button when they're in pain. And we realized for the purpose of orthopedic patients, where getting up and moving and participating in rehab was a key component, that really, they conflicted significantly. The goals of the patient-controlled analgesia and IV pain medicine or narcotics were probably not what we needed. The side effects of opioids were usually overwhelming. So even in the situations where maybe it was relieving some pain, we had to then deal with things like slow gut motility, which caused stomach upset, nausea, constipation, all these things post-operatively that you really didn't want patients to have to deal with. So by reducing the amount of narcotics, they actually can get up and move. The other thing is grogginess, sleepiness, mentation issues with narcotics. If you can minimize those, suddenly people are much more interested, they're much more focused in their rehab. The 4-part pathway is really a pre-op regimen which prepares the patient before their operation. A day of operation, which includes some medicines that they'll take on the same day they're even having their procedure, early in the morning. Things like transacemic acid, which are really more related to their bleeding. That also includes spinal anesthesia and a regional anesthesia that minimizes their narcotic usage. Then their hospital stay combines a bunch of different medicines that are non-narcotic to help them limit the number of opioids that they need. And then the final piece would be the post-operative course, which would be, again, a combination of medicines used. Using that 4-part program, we were able actually to reduce narcotics almost 60% in the hospital stay alone, meaning the 2 or 3 days in the hospital, they took about 60% less narcotics, and their pain relief was as good, if not better, as it was prior to that. So it's been very, very revolutionary. Historically, if you go back 10 years, I would say low back pain was probably what started us understanding that just giving somebody narcotics for low back pain was not working. So it wasn't a condition that met the criteria of acute only pain. These were people that had several exacerbations. So there was always a multimodal approach, even in the medicine. So it was exercise therapy. Some of the medicines were muscle relaxants, some of them were anti-inflammatories, and there may be a narcotic, but it was really a small portion of the entire treatment plan. We took that into standardized procedures like total hips and total knees and said, a lot of these are done the same way, so is there a way to standardize the approach of their pain management starting even before the operations? I think we were trained in medical school and even residency, and this is going back quite a ways, but where narcotics were the first line, I think they're becoming kind of the third line now. And there's other things that we reach for that now, and that has to be the cultural changes. You're still helping people, you're still managing them through the pain, but it's just not a quick fix. You really do want to get back to like really helping people. So now a lot of the time, it doesn't take a lot, is looking somebody right in the eye and saying, I don't think that medicine is going to help you. If you have a chronic pain condition, there's really good evidence out there that narcotics are no better than Tylenol, like I said. And so in Tylenol you can get over the counter and it doesn't cause these problems. So having that conversation with people, we didn't have that before. So I really think that's the key component of the change moving forward. You're really helping yourself and the patients and everybody by adapting kind of this new methodology.